Okay, good afternoon, everybody. My name is Kristen Collins, and today we're going to talk to you a little bit about the diagnostic yield of genetic testing for autism spectrum disorders. I'm going to start off first to tell you a little bit of background. Dr. Zunian Dai will talk a little bit, and then I will return to talk about the second half of the laboratory portion of this talk. So to start off, I just want to mention that sorry, a slight technical difficulty here. Dr. Dai and I are both laboratory directors at Emory Genetics Laboratory, which is a fee-for-service testing center, and that is, our disclosure for today. So later in the talk, you'll be hearing a little bit more about the clinical presentation of autism spectrum disorders, but as a brief background, autism or ASD, autism spectrum disorders, affects approximately 1 in 68 children. The spectrum includes Asperger's syndrome, autism disorder, and PDD-NOS, and you'll hear more about that later. The major domains affected are social interaction, language, and repetitive behaviors. ASD is 4 times more prevalent in males than in females, and there is a 60 to 92% concordance rate in monozygotic twins, while there's only a 5 to 10% concordance rate in siblings. This concordance rates in monozygotic twins versus siblings really argues for the genetic component of autism spectrum disorders. But to date, most individuals with ASD do not have a genetic diagnosis. There have been plenty of guidelines to help clinicians in the approach to clinical management and testing for individuals with autism spectrum disorders. And the ACMG has also issued, or the ACMG, which is the American College of Medical Genetics, has also issued guidelines in helping individuals triage and send their patients for clinical genetic testing. And so what do these guidelines say? So the way the ACMG has approached these guidelines in testing, in encouraging individuals to test for genetic causes of ASD, they've come up with the tier system, or a recommendation for a tiered system. And this starts with the first tier, which includes targeted testing for a specific disorder, if appropriate. If you already know what, or the clinician already has a suspicion for a particular diagnosis in a patient, it makes the most sense to just do targeted testing for that disorder. But if you don't have a specific diagnosis in mind, then it makes more sense to go broader. And in going broader, the things that you should consider as a first-tier test for genetic evaluation of autism spectrum disorders is chromosomal microarray, Fragile X testing, and then also if there is a suspicion for a metabolic disorder, there are metabolic and mitochondrial testing which may be appropriate. If that all comes back negative, the ACMG recommends a second tier of testing. This second tier of testing includes MECP2 testing and P10 testing. And MECP2 testing is really encouraged for individuals with ASD in this guideline who are female, MECP2 being the gene for Rett syndrome. And then MECP2 duplication testing, which would be done by an array CGH, most likely, or an MLPA, or some sort of copy number variant testing for males. And then P10 testing is recommended for individuals who have macrocephaly. That's really sort of 2.5 standard deviations above the mean. So Emory Genetics Laboratory has taken these guidelines for the tiered approach to testing and implemented that in our approach for genetic testing. Or do a little bit about the tier 1 component of our testing.
So as Dr. Collins mentioned, we have a tier 1 testing, combined our strategy from all 3 labs for cytogenetics, microarray, Fragile X testing, and metabolic testing. So I will come back to the cytoarray and the Fragile X later on. For the metabolic testing, if we suspected some metabolic disorders, we can offer urine organic assays, plasma amino acids, SLO screening, and lysosomal storage disease screening. So all these tests can be ordered as a panel or can be ordered separately. We also offer the CytoScan HD microarray from F matrix. The array in the panel is oligo microarray. Most of you familiar with microarray, so I'll go over quickly in case someone is new in this field. So for this oligo array, we using the gene sample from the patient and the control samples. They are labeled differently, use different fluorescent dyes like size 3 and size 5. Then hybrid together to the microarray slides. It's based on you have more material from the patient or from the control, so then you're going to see different pattern. So in this case, on the microarray, we have more material from the patient, so that's why you can see we have 1.4 to 1.5 megabase region shifted higher to +1. So this region contains a gene, PMP22. You all know the duplication of this region is consistent with clinical diagnosis of Charcot-Marie-Tooth disease. So for copy number variation classification, the case I showed you is very easy to make the call because we know this is being reported in multiple publications, so it's well known to cause disease. So this case is pathogenic. For other copy number variations, sometimes maybe we don't have enough clinical literature report, so we can classify them as uncertain. So for uncertain, there's 3 categories: is uncertain, likely pathogenic, or uncertain likely benign. So for those CNVs with very high population frequency, like maybe higher than 1%, so we can classify them as benign. This is really depends on the region. They have Oming disease associated genes or not. So the classification we follow the guideline is we consider multiple factors. So this slide shows you the CNVs detected in our lab from Tier 1 testing for 2,000 cases. So you all know the 16q11.2 is associated with autism. The 22q11.2, this is the DeGeorge region. They also have some autistic features. The 15q11.2, the deletion is being reported in both patient and in the normal control. So this finding is uncertain. So I won't go over one by one. So I think most of you are familiar with this. I just pointed out the green bar show the aneuploidy like XYY, XXX, XXY. Incidental findings, so we're also going to report them. So this slide lists the known copy number variations reported in patients with autism. I think most of you are familiar with this. I just go over quickly. The 1q21.1 deletion duplication, this is the one distal to the TAR region. The one on 2q23.1 is including the MBD5 gene. The Williams region duplication is also associated with autism. So for the 15q11 to q13 duplication, this could be a duplication on the on chromosome 15, or could it be a marker chromosome? So this list is very long, so this is a partial list. A longer list you can find from the ACMG Guideline published in 2013 in the Journal of Genetics in Medicine. So you can read further from that paper. From our test, from these 2,002 individuals, about 171 of them had at least one pathogenic CNV. So the diagnosed yield is about 8.5%. So this is consistent with the literature report. You know, as a single test, the micro yield is really high. So in Tier 1, we also test the Fragile X. So you're all familiar with Fragile X. In male patient, they have a moderate mental retardation. For female, they could range from normal to fully affected, depending on the pattern of X inactivation. They could have some autistic-like behaviors, abnormal craniofacial features like long face, prominent forehead, large ears, prominent jaw, and other clinical features. So the Fragile testing in our lab, we're using PCR method for CGG repeat track sizing. The kit is from Asuragen. We're also doing methylation sensitive PCR for male with very large pre-mutations and full mutations. You all know for male with unmethylated full mutations, they can perform much better. We also have a Southern analysis for any patient with any concerns. We will run a Southern to get the best diagnosis for our patients. This one shows you the result from Asuragen for CGG track size testing. So after the PCR amplification, the PCR product will put on ABI sequencer like 3730. Then they separated by size. So we have the size standard here. So based on the fragment size, we can calculate the repeat size. This screen shows you one of the full mutation control. So this is from a cell line. You all know because there's so many CGG repeat in this region, so the PCR amplification is not easy. Among those 2,002 individuals tested, we have about 1% of patients had a full mutation, and about 0.3% has a pre-mutation. You all know for individuals with pre-mutations, they could have either premature oral failure in some of the female and ataxia or tremor in both male and females, but is more often in male individuals with permutation carrier.
Okay, so this is Dr. Collins again. I'm going to talk a little bit about the second tier of our testing. So as Dr. Dine mentioned earlier, the tier 1 is really the starting point for the genetic evaluation of ASD, because you're going to have the largest diagnostic yield with the chromosomal microarray and the Fragile X testing. However, if those results are negative, you may want to consider the tier 2 testing. And the tier 2 testing at EGL, or our Emory Genetics Laboratory, really consists of a next generation sequencing panel, and the genes on this panel are targeted to those genes that are associated with genetic syndromes that are known to have autistic features, or genes that are associated with essentially non-syndromic autism. as well as genes that are involved in the differential diagnosis of Rett syndrome and/or Angelman syndrome. Included in this tier 2 panel is also a CGG repeat analysis or CCG repeat analysis and methylation status testing for FRAC-C syndrome. If you do this testing, you also have the option for reflexing to a gene-targeted deletion duplication test that we offer that includes those genes that are on the tier 2 next generation sequencing panel. So this is a slide to just show you the genes that are included on this panel. It includes everything from the ACMG recommended P10 and MECP2, as well as some other disorders such as the ARX gene, the PTPN11 gene, and the RAI gene. Some of these include syndromes that have features of autism, as opposed to genes such as the neuroligin 3 gene, which is more associated with non-syndromic ASD. So this is a slide that just shows you the testing for the first 166 individuals referred to our laboratory for this tier 2 panel. I would like to make a caveat that we have since tested a number of additional samples, and perhaps the next time we give this talk, I can include those numbers. And we are seeing a significant increase in the number of positive results that we're finding. But at least for the first 166 individuals tested, we found 10 individuals with pathogenic variants. However, 4 of those individuals just had a single variant in the DHCR7 gene, which causes Smith-Lemli-Opitz syndrome. So they may just be carriers for that disorder. 6 of the 166 individuals tested, or 3.6%, had a diagnostic finding that likely explained their ASD. About 13% of individuals that were referred for testing for this tier 2 panel were negative. And then as a side note, about 339 variants of unknown significance were identified. So I would like to take a minute just to talk a little bit about how we classify variants here at EGL. We follow the ACMG recommended guidelines that were published in 2015. And this is a 5-tiered system. So we classify variants as pathogenic, likely pathogenic, variants of unknown significance, likely benign, and benign. And here's a little bit of explanation as to how we call each of these. If you want further information, you can refer to the 2015 ACMG paper, as well as information on our website that talks about how we classify our variants. But we are using the standard 5-tiered system and the standard guidelines that are recommended for clinical genetic testing. So this table here talks a bit about what exactly those diagnostic findings were that I mentioned in the previous slide. So this is a list of all the pathogenic variants that were identified in the first 166 cases. And you can see everything from FOXP1, which is associated with intellectual disability, with language impairment and autistic features. This was a frame shift mutation, pathogenic variant. It hadn't previously been reported, but it is of a type of variant that we would expect to cause disease. We also had a frame shift pathogenic variant identified in the UBE3A gene. Parental testing had not been done, so it's unclear the parent of origin, but since the patient had a clinical phenotype, we suspect that it is the diagnostic finding. Everything from FOXG1 to TCF4, Pitt-Hopkins syndrome. I mentioned those 4 individuals who had 1 pathogenic variant in the Smith-Lemli-Opitz gene, but no second variant in this gene was identified. However, we did refer the providers to do biochemical testing if this was something that they felt was a good fit for their patient. And then additionally, we had 2 individuals that had pathogenic variants that were identified by the gene-targeted arrays. One included a large deletion, a deletion of exons 9 through 29 of the SHANK3 gene, which is associated with Phelan-McDermott syndrome, and then another individual who had a deletion of exons 4 through 27 of the CAS gene, which is associated with X-linked intellectual disability. So I mentioned that we did have a good number of variants of unknown significance identified. Unfortunately, this is sort of the infancy stages of large-scale genetic testing. Hopefully, as more individuals are tested, as more information is known about population variation, the number of variants of unknown significance that are identified will decrease. but at least in the first 166 patients that we signed out, the majority of them were missense variants, about 50% of the variants of unknown significance that were identified. But we saw everything from in-frame deletions, in-frame duplications, large intronic deletions, multi-exon duplication in a gene that is may or may not have reports of duplications involved. So this is the data that we find on the VOUSs. If we further break this down, you can see that 145 of these 166 individuals tested had at least one variant of unknown significance. And this could be a result of the clinical laboratory just not receiving enough phenotype information to do an appropriate assessment of that variant. It also stresses the importance of parental testing. If we identify a variant of unknown significance in a proband that is a dominant, associated with dominant disease, and then it's found in an unaffected parent, that reduces the suspicion that that's a disease-causing variant, and then we could potentially reclassify that variant. It also may suggest, the idea that seems to be floating around in the field right now is this combinatorial or multigenic threshold of a number of genes working together in a pathway. This is simply a hypothesis. This is not proven by this data at all, but simply noting that we have a number of individuals who have significant variants of unknown significance identified. But if we go back to the total diagnostic yield, so Dr. Dye mentioned earlier, the chromosomal microarray plus Fragile X testing for Tier 1 had about an 8.5% yield for the microarray, or the chromosomal whole genome array, and then about a 1% diagnostic yield for the Fragile X full mutation. And then for our Tier 2 testing, which included, for this analysis, the next generation sequencing panel, the FRAC-C testing, and then the reflex gene-targeted microarray, we had a diagnostic yield of about 3.6%. So really, what's next? The next thing to consider if you do a Tier 2 testing is perhaps medical exome testing or exome testing, which sequences the whole exome and then plus has extra coverage of medically relevant genes. In our laboratory, we have a medical exome, which has about 92% of the whole exome covered and has really targeted coverage for the 4,600 or 4,600 known disease-causing genes, with at least about a 20x read depth across the whole exome and a mean read depth of 100x coverage. Additionally, our laboratory allows for an exome boost. So essentially what this is a free panel that's associated with their exome. So if you order the exome and then you want to boost it for the NGS testing, for the panel testing, you could be sure to have increased coverage of the autism genes that are included in our panel as part of this exome testing. And then the other thing to note is MV class, and I'm going to talk a little bit about this later, but this is really our catalog for all the variants that we identify in our laboratory. So this is just an example of an exome that was referred to our laboratory, and the individual had autism spectrum disorder and intellectual disability. This clinician chose to run the intellectual disability panel, and they identified 2 variants of unknown significance, one in the neuroligin 3 gene and one in the NSDHL gene. And you might initially be suspicious of the neuroligin 3 change, but it's a silent change, so that might reduce your suspicion. So the clinician decided, okay, I think we're going to run the whole exome sequencing. And when they ran the whole exome sequencing, they found a pathogenic variant in a canonical splice site in the GRIN2B change. So this really is the likely cause of disease in this individual. The gene isn't included on any of our panels, although it may as time goes forward. One thing to note about the genes that are on our panel is we do periodic review and curation of those gene lists. And so as more evidence becomes available to support causality of genes for specific phenotypes, we will include. If we do sort of a comparison of panels versus exomes, you can see that the time to order a panel really is if you have a clear-cut phenotype and you think that you're pretty convinced that the this is what your patient has clearly, excellent intellectual disability and not really much anything else. But if you have a complex phenotype or overlapping phenotypes, a panel may or may not be the way you want to go. You may want to consider the medical exome because that will get you greater coverage across a number of genes. And lastly, I just kind of want to mention data and the variants that we see here at Emory Genetics Laboratory. So one of the things that's really important for clinical laboratories is to be thinking about how people can have access to your data, or essentially their data if it's their patient's information. And so we submit all variants that we've identified in our laboratory to ClinVar, which is an NCBI-supported resource that's curating variants and classifications across multiple clinical genetic testing facilities here in the United States. And you can see here that we, to date, have submitted over 5,000 variants to ClinVar. The majority of them, 94%, are concordant with other laboratories that have submitted data. We do have some discordant calls, and this actually becomes a really interesting next step, is that these laboratories that have discordant calls get together and we try to resolve our calls and see what information one laboratory has that the other doesn't have to make it so that everybody is operating on a level playing field here. So we do submit our data to ClinVar, but in addition to that, we also have something on our website which is called MV Class. And basically this allows anybody to query both a gene or a particular variant and see if we've identified or what we have identified here at Emory Genetics Laboratory. So if you're interested in what variants has EGL seen in the P10 gene, you can put P10 into our search box and a list will come up of every variant that we've ever seen in the P10 gene and what we've called it. Or if you're a provider and you ordered a testing on your patient and there was a particular variant of unknown significance that you identified, that was identified in your patient, and they're coming in for their 1-year follow-up, you could input that variant into the query and you can look and see if EGL has changed the classification of that variant in the past year. And if we haven't, and you would like us to take a look at this and at this variant again before your patient comes in, you can request a re-review by an individual, a director or a variant analyst here at EGL, and we will take a look and see if there's any new evidence for that variant. And then additionally, you can do whole-scale downloads of our database. So we're trying to make this as open and free as possible and that everybody has access to our data so that we can all have a conversation about what the classifications are and what information was used to classify variants. And people are using our MV class database. And you can see here that we've had hits from 47 states in the United States of individuals querying our database, looking at what we call variants. And then we've had 72 countries that have had individuals logging into MV class to see what we classify variants. So, and there's access, people can email us and ask us specific questions and we'll do our best to respond in a timely manner. And so that's one thing that really allows the data to be as transparent as possible. And so lastly, just some acknowledgement slides here before we move to the next portion of our talk, which will be the clinical component.
Thank you, Dr. Collins and Dr. Day, for your presentation. Next, we'll be moving on to Dr. Sido. She is a pediatric neurologist with Children's Healthcare of Atlanta, as well as an assistant professor in the Department of Pediatrics and Neurology at Emory University School of Medicine. And she will be providing us with a clinical presentation of patients with this disorder. Thank you, Dr. Sido.
Thank you, Derek. Ideally, I would have liked to presented this first, but I think either way the information will be transmitted, and so hopefully not all is lost. So what I wanted to review was the clinical features of autism spectrum disorders. So first we'll review some basic definitions, go over the DSM-5 criteria, go over some early signs of autism, talk about the goals of the medical and neurological testing, and then we'll go through some typical and atypical neurological findings. Don't have any disclosures or conflicts of interest. All right, so what is autism spectrum disorder? It is a behaviorally defined syndrome. And it's a neurodevelopmental syndrome that really represents the response of the very vulnerable developing brain to a variety of different insults. And so remember, it's behaviorally defined, and the core symptoms of autism spectrum disorders involve impairments in sociability and atypical behaviors. So that's really very key in remembering that reciprocal social communication is the core deficit in autism spectrum disorders. And along with deficits in social communication, children have very atypical behaviors. They're very inflexible, so rigid in their thinking and their actions. They have atypical behaviors such as restricted interests, very narrow focused interests that are oftentimes very unusual, and they have repetitive behaviors. So the domains now really look like this. It is a core deficit with social communication and atypical behaviors. The two of these features define autism spectrum disorder. So frequently we talk about complex autism versus essential autism. And again, like I've said, it's a behaviorally defined syndrome. And so even though we have a unique phenotype, we don't have one specific pathology or one unique etiology for autism. So we frequently talk about the autisms rather than autism. And so many people talk about syndromic autism or complex autism, essentially meaning the same thing. And what that is what we heard earlier, autism with a definable cause or a discernible physical finding, imaging characteristics, and these are single gene disorders like Fragile X or Angelman's, tuberous sclerosis, frequently associated with intellectual disability. And then we talk about non-syndromic autism or essential autism. People call it many different things. And that's really the autism spectrum disorder without an identifiable etiology, which, you know, over time, this category should become smaller and smaller as the other category grows, and we're able to investigate and discern an etiology for autism spectrum disorder. What are we left with now? How do we diagnose autism? There's no universal biomarker. We're left with behavior. Unfortunately, that's what we have to diagnose this disorder at this point in time. And why I say unfortunately is because it can be hard to diagnose this syndrome based on behavior, especially in office settings which are sort of artificial to begin with. You take a child who has potentially severe behavior problems, and you're trying to assess their social communication, and then you put them in this artificial office setting, and it can be very tricky in order to diagnose this, because we really are resting the diagnosis based on observation of the child's behavior. And so for now, we're stuck with the Diagnostic and Statistical Manual as our Bible for diagnosing autism spectrum disorder and other psychiatric illnesses. But so the DSM has gone through many different iterations, and in 2013 the DSM-5 was laid out and has identified, and we use two domains that are, again, getting at the hallmark of the clinical features of autism spectrum disorder. This is a very busy slide. I'm going to walk you through these two core domains. So the first domain has to do with social communication, as I mentioned before. And so social communication deficits need to be present across multiple different contexts, not just one setting. And they let's just go through some examples, actually. So so social emotional reciprocity, that really is universally affected in all kids with autism spectrum disorders. And so this can be something very subtle, like an abnormal social approach, not knowing how to interact with other children, not knowing how to approach other children, not being able to have a back and forth conversation. You know, many of us have come across children like this where it's really they're just talking at us and talking and talking and talking and not checking in to see whether the person on the other end is listening or not, and maybe that other person has fallen asleep, but this child is just going on and talking regardless of whether the listener is interested. It can also encompass problems with sharing interests or emotions, and really not understanding the nuances of social interactions. And again, that's really something to remember. That's the core deficit in autism spectrum disorder, this problem with social reciprocity. Next, we go on to deficits in nonverbal communication behaviors. Again, we all use nonverbal communication when we are interacting socially, and kids who have autism spectrum disorders have great difficulty coordinating nonverbal behaviors, gestures with their interactions to other people. So their eye contact is either reduced or very abnormal. Sometimes it's really a prolonged stare and sort of looking longer than seems to be appropriate. Frequently it's a reduced eye contact. But it's not using body language in a typical kind of fashion, and not understanding body language also. So that if I have my arms crossed and I'm looking away and absolutely not, you know, giving you all the clues that I have no interest in this conversation, it's the person with autism spectrum disorders that can't read that body language and keeps talking despite the fact that I have given you the nonverbal cues that I'm done with the conversation. So that it also extends into facial expressions, not being able to read facial expressions. And so these are universal deficits. If we go onward, individuals with autism have a hard time maintaining relationships, making friends. They often have different interests, and so they just have a hard time keeping up developmentally appropriate relationships. So that really is the social communication deficits in autism spectrum disorders, so that first domain that I talked about. The second domain has to do with atypical behaviors. So we're talking about very unusual behaviors that often are very narrow interests, very circumscribed focus interests above and beyond what seems to be typical. So let's walk through some of these examples. So many times children will have repetitive, in addition to their interests, they will have stereotyped or repetitive motor movements, repetitive speech as well. And so these children have, just to give you an example of repetitive speech, they are oftentimes echolalic. So if I say, "How are you?" they'll say, "How are you?" Exactly with the same inflection pattern. Their speech can be echolalic in a delayed fashion. So they might they might say things that they've heard from TV shows and use those scripts. It's sort of like, you know, just reciting dialogues or certain rote phrases from TV shows later on in time. And frequently kids can just recite huge parts of dialogue from movies or TV shows, things like that. They're very repetitive in their play, and so rather than engaging in pretend play or imaginative play, which all children do as part of a normal developmental process, they are very repetitive in their play, and they line toys up, or they get very focused on the parts of the objects, and they're flicking the wheels, and they're just moving cars back and forth in a very repetitive, perseverative fashion, rather than engaging in any sort of pretend imaginative type of play with these objects. The other atypical behavior is this behavioral inflexibility that I spoke about before. These children need to have routines, and if one part of a routine that is usually nonsensical to someone without autism, but if that routine is changed, these children will fall apart. So they have very ritualized patterns of behavior, and things have to follow a certain way, and any kind of small change causes huge problems, and you know, can really be very disruptive in a family's life. So I think that's probably clear. Moving on, these children have very abnormal fixations, and again, very restricted ranges of interest, and so they're very preoccupied with certain objects, obsessive in many ways. They need to have these things all the time. They get strongly attached to them more than what's considered typical, and their interests become very perseverative as well. And then the last part of the atypical behavior category is something new to the DSM-5, has to do with sensory input. Many of these kids have abnormal reactions to sensory aspects of the environment. They're either hyporeactive or hyperreactive. So these are the kids that are constantly smelling things, sniffing things. They have to feel things. They might not like how things feel frequently. You know, the parents will say, well, just a tag on a shirt, they won't wear that shirt. They cut the tags off of all the clothes of these children. Sometimes the seams inside socks will bother them. They'll have to put the socks inside out because just the slightest abnormal touch causes them great distress. And so, you know, just the opposite too, some kids really get very focused on lights and ceiling fans and things that provide sensory input to them in a way that seems to be something they're seeking, looking out for. So those, what I just described are the core deficits, the two core areas of social communication and atypical behaviors. So the DSM says that, you know, the symptoms really have to be present early on in the developmental period. Now the part that they had added to this version of the DSM is that it has to be present, but it may not be really apparent until later on in life when the social demands exceed their capacity. And so this is important for kids who are, you know, more higher functioning. Looking back in retrospect, these things should have been present, but it may not have been a problem until later on in life. And number D really just says that it has to be causing impairment in some aspects of their functioning. And then the final part of the diagnosis is that, you know, these disturbances that they have in social communication and in their behavior should not be better explained by something like an intellectual disability or a more global developmental delay. And if they do co-occur, because frequently kids who have autism spectrum disorders have intellectual disability, the hallmark of social communication really should be below that expected for that general developmental level. Again, speaking to the fact that autism spectrum disorders the hallmark of autism spectrum disorders is this deficit with social reciprocity or social communication. So, what are the goals of the medical and neurological evaluation? So we have reviewed how we define autism spectrum disorders, some examples of what children may look like, and now what's the point of a medical or neurological evaluation? Well, you know, what we're trying to do with these kids is we're trying to diagnose a condition in the hopes that if there is a specific medical therapy, for example, if the child has epilepsy, the child has a metabolic disease, like we heard earlier, has Rett syndrome, Fragile X, we want to be able to give them a medical therapy if there is one, for things that are treatable. And what we're really talking about are metabolic disorders in these categories, because many of the metabolic disorders are not treatable, but there are ways that we can help alleviate some of the symptoms, and we would want to recognize that a child has a metabolic condition because there are certain things that we want to do in order to not make that child's condition worse. So that could be dietary related, supplement related, etc. So along the same lines, when we're doing a medical evaluation, we're trying to make a diagnosis in the hopes that if we have a diagnosis, we can make more informed discussion about recurrence risks for subsequent pregnancies, and that's really important for families. You know, they have one child who has autism, and if we can identify the cause of that autism and we know what the inheritance pattern is, we can provide a more educated discussion about recurrence. So we've heard about this a little bit, providing genetic counseling to unaffected family members. And then other benefits, I think that, you know, when you identify a specific etiology for the autism, you may learn about other medical problems that go along with that autism, go along with that condition that you might not screen for. You know, children who have Duchenne muscular dystrophy, well, that's a fatal neuromuscular disorder. Well, making that diagnosis is clearly important because, well, we do have therapies that can lessen the symptoms, but we also want to tell the parents about what the road ahead, what the road ahead is going to be, and what things may pop up. So kids who have Duchenne muscular dystrophy have cardiac problems that they might have later, may have respiratory problems, and so, you know, making a diagnosis alerts us to other potential medical issues. Making a specific diagnosis means that we might avoid any other unnecessary testing, because, you know, at the end of the day, families really do find great comfort in knowing what the cause is, even if we can't do anything to treat the cause. And I, you know, doing this a lot, I know that a lot of times families will really appreciate knowing why, even if it doesn't change things. And the biggest part about knowing why that I think is helpful is that many times families will go throughout the lifespan of the child searching for reasons, and lots of medical testing gets done along the way. And so if you've identified what the etiology is, you can avoid and stop some unnecessary testing going forward. So again, I've mentioned this, more information about prognosis if we have a specific etiology, and I've also said this, the families really, really do find comfort in knowing a specific reason. And I always tell parents about this last one, that the future advancement, you never know what specific therapies may bring, and what specific therapies may arise. And so if you don't know whether you have a certain disorder, then you'll never know whether or not you're eligible for things that may pop up at a later date. I'm going to run through this because I think we're really at the end. Typical findings in autism spectrum disorders: heads are large, not at the 3 standard deviations above the mean, more like the 75th percentile is average in these kids. They almost all have oral motor apraxia or dyspraxia, and many different sensory motor deficits. I talked about sensory seeking, putting things in their mouth, being preoccupied with sensory features. Hypotonia is very common, motor apraxias, motor stereotypies, which are sort of the hand flicking, body rocking, toe walking, and gaits that are very that lack fluidity. So many different sensory motor deficits that are seen. All of what I just said is very common in essential autism. So the things that are atypical and should tip you off as to what tip you off about the possibility of a syndromic autism spectrum disorder or a complex autism are what I've listed here. So these are findings that when you see them, this is not garden variety simple autism. This is more complex and provides a clue that maybe there's an etiology you can find. So I won't go through all of these, but this is a list. Epilepsy, just really quickly, co-occurs in kids who have autism. About a third of the individuals will have epilepsy. Happens in early childhood or adolescence. About 10% probably due to genetic syndromes. Many different types of seizures, usually complex partial though, and the treatments are the same. And here I've just listed the some of the risk factors for epilepsy. So I know I'm approaching the end here, and I think we'll skip this. And I'll just end by saying that I'm grateful for the forum to present the clinical phenotype, and I look forward to partnering with the Emory Genetics Lab in trying to find more causes for autism spectrum disorders in the future. Thank you.
Thank you, Dr. Sado. That was a great presentation on clinical perspective of this patient population. At this time, I don't think we have any questions, so I will thank everyone for their time and joining us for this webinar today, and apologize for our audio complications, but thanks again to Dr. Day and Dr. Collins, as well as Dr. Sado, for providing a well-rounded presentation on autism spectrum disorder.